before I tell you about our progress following the NC Pod report, I thought I'd tell you where we started before this. So a wee bit of history. So in 2005 we were involved in Cardiff in the Surviving Sepsis campaign in Wales. This is based on the Barcelona Declaration, and that was a kind of a global movement to aiming to tackle the 10th most common, what they called the 10th most common cause of death. And this involved 2 care bundles, the maintenance bundle and the resuscitation bundle. So over the next few years in Wales, we developed what they called a RAILS collaborative, and the RAILS stands for Rapid Response to Acute Illness Learning Sets. And essentially these were 4 care bundles, all underpinned by competence, which we measured on every ward in Wales. And one of these care bundles was obviously around the Sepsis 6. Then in 2012, we were very fortunate, we're a small country, that we were able to embed the National Early Warning Score in all acute hospitals in Wales. And then by 2013, sepsis became a Tier 1 priority for our Welsh Government. So we implemented news, and many of our charts look like this. The charts may vary in every hospital, but the response doesn't, it's exactly the same. And then we became a Tier 1 priority for Welsh Government. Well, what does that mean? That means that we report our Sepsis 6 compliance on all awards and all emergency departments to Welsh Government. Then in 2015 we had the NC Pod Just Say Sepsis, and this was followed the following year by the NICE guidelines and then the new NICE definitions for sepsis. So we took all this on board, and with NC Pod recommending from their Just Say Sepsis report that all hospitals should have a formal protocol for the early identification and immediate management of patients with sepsis. Last year we developed our Sepsis 6 pathway, which was based on the UK Sepsis Trust pathway. There's some minor modifications. We couldn't get our paediatricians to allow this tool to be applied to patients under 16, so our tool applies to patients over 16. We made a modification on the back of it because we don't have electronic observations anywhere in Wales at the moment. So this part we peel off, and it's a sticker that goes into the patient's notes. And we also wanted to please our microbiologists, so we also have a sticker for antimicrobial review after 48 hours. So we implemented that, and that's been running for 12 months now in Cardiff, and it is the red flag sepsis. NC Pod recommended that the protocol should be easily available to all clinical staff who should receive training in its use. Well, we went over to the Sepsis 6 trolleys in Cardiff. We received some funding after application, and we used the trolleys rather than anything else because it's like a one-stop shop for sepsis. Everything can be contained in there. All ward doctors know exactly where to find the trolley, and that everything will be in there, including the pathway, so that it can be wheeled to the patient's bed area. We developed a driver diagram with, I think, was a very ambitious aim to improve compliance to 95% reliability, but we failed on that, and I'll explain why. But we do review the driver diagram in terms of where we are with education, assessment of knowledge, what resources we've got, our leadership at ward level, which is key, communication we've talked about already, which is key, and our policies and procedures. We developed a intranet page which all staff can access, and within that are e-learning, YouTube videos, etc. All our clinical guidelines will be on there, and we update this regularly. And although we're not electronic in any way in Cardiff, we're working on what we call the Sepsis Star. So this is a treatment delivery record which replicates the paper form, and we started using this in our emergency department on our clinical workstations. The emergency department, basically because they're already used to using the clinical workstation for everything, and they very successfully used it with the stroke pathway. So we're hoping that this will generate some accurate data for us as well. They said that compliance should be regularly audited. Well, I've said that we have to report our compliance with Sepsis 6 to Welsh Government every month. And all our compliance and all our health boards kind of looks like this. We seem to be getting better, but at the moment all we're reporting is our compliance. Now that will mean something different for every health board, because for us we're only collecting data 12 hours a day, 7 days a week, and not on all wards. So we do not know what happens outside that 12-hour period. But what I will do every month is look at our data and look at our reasons for non-compliance, because for me that's more relevant. And our non-compliance, I feel to see how you can really achieve 95% compliance with a sepsis 6 bundle, because these are real examples. The patient was non-compliant because hemodialysis was the priority at the time. No point giving antibiotics to somebody if you're going to flush them out again. So these were real reasons for non-compliance, but at least we could go back and have that dialogue at ward level with the junior doctors and the nursing staff involved. Also, I don't think compliance data is any good unless you're looking at it alongside our mortality data. So you might be 95% compliant, but you might be only reporting 1 patient, and if your mortality data is not getting any better, then so what? Your improvement isn't really effective. So this is an example of 2 hospitals in Cardiff, the University Hospital Wales and the University Hospital Landock. Both hospitals had news introduced at the same time, and one hospital, University Hospital Wales, we introduced the Critical Care Outreach Service. And these are absolutely key in delivering education at ward level. And they, I think, show that they have made a massive impact in our mortality data with sepsis. In Landock Hospital, mortality hasn't changed since 2010 with sepsis. It remains high at 33%. And yet in University Hospital Wales over the last 2 years, our mortality's gone below 20%. So it's really key to look at data as a whole and not just in isolation. Also in Wales, since 2014, we've done an annual point prevalence study, and this happens over a 24-hour period for 1 day a year. And what we do with this, we use medical students, so we train 120 medical students every year on sepsis. We train them how to collect the data, how to recognise it, and they spend a whole 24-hour period in their own time doing this, and throughout every hospital in Wales. So the amount of data that we're collecting from this will help us inform and move forward as well. So the protocol should be updated in line with changes to national and international guidelines and local antimicrobial policies. So this is key for us in terms of involving our microbiologists in implementing this, and actually it's going to be key for us in trying to get an antimicrobial pharmacist employed, because we currently don't have one, and our reviews are poor. So this is a piece of work that we're going to take forward as well. Early warning scores, such as you, should be used in primary care and secondary care for patients where sepsis is suspected. Well, you've heard me say we've got it in secondary care, and primary care is now our main focus. So we know that we want GPs to treat sepsis in a timely way. We want them to treat it as an emergency. And this is a piece of work that like I said, I'm a consultant nurse in critical care, but I'm currently spending most of my time with Welsh Ambulance Trust and in primary care. We've just completed a randomised controlled feasibility study with Welsh Ambulance in looking at how feasible it is to take blood cultures at the scene and to give the first dose of antibiotic. NCPOD tells us that 70% of sepsis cases originate in the community. So for us, this piece of work is going to be key. We're introducing news, and the Welsh Ambulance Trust currently do use news, and we're having that common language that we talked about earlier across the whole board. Depending on the results of the feasibility study, hopefully this will progress to a multi-centred RCT. And we're also discussing with our paramedics about rotating into secondary care, so we can have a much more joined up approach along the whole of the patient pathway. So currently in Wales, we're rolling out news into the community. We're providing sepsis education with our district nurses, our healthcare support workers. 2 years ago, I knocked at GP's doors saying, can I come and talk to you about sepsis? And it was a closed door. But just 2 months ago, I had a phone call from a GP surgery who had a patient who had recently died of sepsis, and the family's only request was that all the staff in the GP surgery was educated around sepsis. So I went along and did a teaching session for them. And when I got back to the office, I had emails from another 7 GPs centres in Cardiff alone. So the message is getting out there. We are breaking down these barriers. We're also implementing news into care homes, and that's a massive piece of work that Public Health Wales is leading on. NCPOD also recommended that a booklet was provided for patients and relatives, that it was easy to understand the information inside and the recognition of sepsis and its long-term complications. So this year, on World Sepsis Day, following a year's work, we produced our Life Post-Sepsis booklet. And this was a piece of work that we did with sepsis survivors throughout the UK. We held focus groups with them, and every iteration of this booklet they commented on and came back to us, and we got the UK Sepsis Trust to publish this for us. So this work took place in Cardiff, and basically it helps to signpost sepsis survivors, but more importantly it allows that conversation with GPs. Patients felt that they were going to GPs with symptoms of hair loss, of insomnia, and they didn't really understand why they were suffering this. GPs didn't really understand it either. So this is all about helping to normalise these issues. This is a normal syndrome that will happen post-sepsis for most people. And it also signposts them for self-help organisations. GPs quite like this booklet now in Cardiff. So we're a small population, we're only 3 million. We've only got 7 health boards. We've got 2 trusts. One is the Velindre Cancer Trust and the other is the Welsh Ambulance Trust. So it's easy for us to communicate really with each other. It's easy for us to embed processes. It was easy really to embed news across all hospitals in Wales. So we've got the right tools to get things right in Wales. What else are we looking at? I'm not going to talk too much about AKI, but we are rolling out AKI electronic alerts across the whole of Wales. So this will alert our critical care outreach teams to early indications of an early kidney injury. We're rolling out the news. We're standardising training across Wales through e-learning. We love the SOS database from England, and we're replicating that for Wales, and we're developing a sepsis register. And although I'm not going to talk about AKI, I thought these are probably just akin to Wales. I don't know if they're used in England at all, but we involve patients in their care with safe kidney. So we ask them to wear a bracelet and then to report back to the nursing staff how concentrated their urine is. And then we have what we call the wee wheel, which is a calculator that supports nurses as well. So there is AKI and sepsis are closely linked. And I think the way forward for us for the next 12 months, 24 months, is based on a tool that was developed in Nottingham, which is a tool for, it's like a traffic light system for all patients that are admitted to critical care, where they feed back the sepsis care to all the healthcare professionals involved, right to the consultant, down to the healthcare support worker. And it's an amber, red or green, and if it's red it's not good. It means that the care was really poor, obviously, but if it was green it meant the care was really good, and this is something that other areas can learn from. So they feedback positives and the negatives, and what Nottingham have been able to show is significant improvement with compliance and reduced mortality. So this is a piece of work we hope to take forward with this in the future. Thank you very much.